Good evening, everyone. My name is Helen Taguri, Manager of Patient Programs at Crohn's and Colitis Canada. I'm very pleased to have this opportunity to moderate tonight's webinar and to learn more from our guest speaker, Dr. Talia Zenli. I'd like to start by welcoming everyone to the first webinar in the 2018 Education Series. Tonight's education webinar, New and Emerging Treatments for IBD, is hosted by Crohn's and Colitis Canada and made possible through an education grant from Pfizer. A link to a recording of tonight's webinar will be emailed to you for future viewing. For those of you who are new to webinars, I'll quickly run through the logistics and how you can ask questions. Right now, all participants are automatically muted so that everyone can hear the presentation and we can capture the webinar recording without audio interference. If you would like to ask a question at any point during the webinar, you can type it into the chat box. Simply look to the right of your screen and you should see a questions field. At any point during the webinar, enter your questions there and we will make note of it. During the Q&A portion towards the end of this webinar, we will try to get to as many questions as we can. If you are experiencing technical difficulties, you can also type your issue into the chat box and we will try to follow up with you directly. If you are having trouble hearing the speaker, it may be your computer's audio setting. Try calling in with the phone number provided using a mobile or landline phone. Great, we're ready to get started. Crohn's and Colitis Canada was established in 1974 by a group of concerned parents of children with Crohn's disease and ulcerative colitis. We are a national charity with more than 65,000 supporters and 80 volunteer groups and chapters across the country. Our mission is to find treatments and cures for Crohn's disease and ulcerative colitis and to improve the lives of children and adults affected by these diseases. We want the general public to be aware of these chronic diseases and the toll it takes on the nearly 250,000 Canadians living with Crohn's and colitis. Crohn's and Colitis Canada has funded over $115 million in research to date. That makes us one of the largest funders of Crohn's and colitis research in the world. Tonight's webinar is the first in our 2018 education series and is part of our patient education programs. Other programs include the Gutsy Peer Support Program, Go Here Bathroom Access Program, and the IBD Scholarship Program. Additionally, we provide educational resources that cover a variety of medical, social, and psychological topics related to Crohn's and colitis. If you would like more information, please visit our website at www.crohnsandcolitis.ca. I'd now like to introduce our speaker for this evening's webinar, Dr. Talia Zenli. Dr. Zenli received her medical degree from the University of Vermont. She completed her residency at Yale University, where she served as chief resident. She completed 3 years of subspecialty training in gastroenterology at Harvard University, where she had a clinical focus in inflammatory bowel disease. Thereafter, she joined the faculty at Brown University as an assistant professor and acted as the director of the Inflammatory Bowel Disease Center at the Women's Medicine Collaborative. Dr. Zenli joined the Division of Gastroenterology at Women's College Hospital in 2014 as an assistant professor of medicine at the University of Toronto. She has a clinical interest in women's gastrointestinal diseases and inflammatory bowel diseases. You can check out her website at bellyblog.ca or you can follow her on social media. Dr. Zenli, it's now over to you.
Thank you very much. And thank you everybody who's participating in the webinar this evening. So I'm going to quickly run through the agenda for what I plan to talk about this evening, and then we'll get started. So in order to have a conversation about the newer and emerging therapies in IBD, inflammatory bowel disease, I think we need to understand what is IBD. I'll then talk about what are the goals of treatment. We'll run through the available treatment options, and then we'll focus on what some of those newer therapies are. So bear with me for a minute as I try to get to the next slide. All right, so I'll start talking and hopefully the slide deck will catch up behind me. But what is IBD? So inflammatory bowel diseases are made up of Crohn's disease and ulcerative colitis. So these two diseases differ, but they're from the same family of inflammatory bowel diseases. Crohn's disease is different from ulcerative colitis in that, well, I'll start with ulcerative colitis. It involves only the colon, as the name implies, which is also the large intestine. And it involves it in a continuous fashion, starting from the rectum and working its way upwards towards the small intestine. That's relevant because everybody with ulcerative colitis has to have their colon involved, and it always starts at the lowest end, meaning at the rectum. This differs from Crohn's disease, which can involve any part of the GI tract from mouth to anus. Ulcerative colitis is what we call a mucosal disease, meaning the involvement is limited to the inner part or the mucosa of the GI tract. So if you think of the gut as a garden hose, it's as if it only involved the inner lining. Whereas Crohn's disease, we call a transmural disease, meaning it can involve any part of the full thickness of that garden hose. That's relevant when we talk about some of the complications. So if you think of, again, using the analogy of the garden hose, if we only saw involvement of the inner rubber part, then anything inside the hose would stay in. Whereas for Crohn's disease, if you think of puncturing that hose, you can have things seep out. And what's in the gut, we see bacteria and stool. So when you lose the integrity of that gut wall, as you would in the transmural inflammation that we see in Crohn's disease, you can have complications because stool and bacteria are seeping out. And those are abscesses and fistula. And so when we see that in people, that sort of defines Crohn's disease as opposed to ulcerative colitis. Here we go. Okay, so this is what I was describing earlier. So you can see with ulcerative colitis, it starts down below and can work its way up, whereas Crohn's disease can involve any portion of the GI tract, including the small intestine or even the stomach. And the reason it's also relevant to mention this is because though Crohn's disease can involve any portion of the GI tract, it doesn't have to. And the other thing I'll mention is that Crohn's disease can have what we call skip lesions, which are areas of normal tissue in between areas that are diseased, as opposed to ulcerative colitis, which is a continuous involvement. The reason I say that it doesn't have to have these things is because some people do present with involvement of their rectum in a continuous colitis that works its way up. And we may think initially that that's ulcerative colitis, but then as the disease declares itself, we may see involvement of an upper GI tract, or we may see some of those transmural complications, and the diagnosis will then change. But for the most part, when we see a continuous colitis, we call it ulcerative colitis. And when we see a more patchy disease or involvement of anything other than the colon, that's suggestive of Crohn's disease. As I said, there's overlap. These are all inflammatory bowel diseases. These can affect men and women equally. There are generally two peaks, one at age 30 and one at age 60, but that doesn't mean that you can't get diagnosed at any age in between that. So anybody at any age can be diagnosed from childhood into late adulthood, and these affect men and women equally. So what is the goal of treatment of IBD? So the first thing we do is we want to establish a diagnosis. Once we've done that, we want to induce remission, which means we want our patients not only to feel better, but we want them to be healed up inside. And I'll talk to you a little bit about that in a minute. So we want to induce remission with therapy, meaning we want to get you feeling better. The next step is maintaining remission. And what I mean by that is, unlike certain illnesses, like if you think of pneumonia or a flu, you make a diagnosis of that, you may treat somebody, and then they don't have pneumonia or flu anymore. Crohn's disease and ulcerative colitis are chronic inflammatory autoimmune diseases, meaning they don't go away. They're always going to be there. The idea is that we get the symptoms and the disease under control. So we need to maintain remission, which is an ongoing lifelong process. Ideally, we'd like to do that without steroids, and I'll tell you about that in a second. We want to minimize long-term toxicity of our medications, and the ultimate goal is to enhance the quality of life. So how do we do this? We think of something called mucosal healing. So when I said before we want to induce remission, 10 or 20 years ago, before we had the therapies that we have now, remission was defined as clinical remission, meaning a patient was diagnosed and treated, and then they came into the doctor saying, I feel great. And we said, that's great, you're in remission. What we found is that some of those people went on to flare up and others stayed well. And when we looked to figure out which is the group that stayed well and which is the group that flared up, we found that the people who were all healed up inside, meaning there was no inflammation, did much better. And we call that mucosal healing, meaning we want to heal up your mucosa, not just so that you're feeling better, but that you're actually healed up inside. And we think that by doing that, we can change the course of the disease, meaning we can prevent flare-ups down the road. So ideally, we want to prevent hospitalizations, avoid complications, and prevent surgery. So these are our overall goals of therapy. And when I talk to you in a little bit about what some of our therapies are, we'll often come back to this. Does this therapy meet our goals? So these are what our goals are. So just to summarize, we ideally want a steroid-free remission, and I'll tell you why in a little bit. We want a complete remission, and that's what I mentioned, getting healed up inside. How do we do that? So we think that by treating people early and aggressively, we can achieve what we call deep or complete remission, and we think that that's our best bet for changing the natural history of the disease, meaning getting you all healed up and preventing flare-ups down the road. And as I mentioned, we need to have some maintenance of remission. So and a similar analogy that I give is if you can't see and you need glasses, you put glasses on and you can see, but it doesn't mean you can take the glasses off 6 months later and see. So we need some sort of maintenance therapy because the IBD is never going to go away. We just want the symptoms and the inflammation to be gone. The disease is always there and we're always going to need to manage it. Similarly, we try not to make changes in medications to people who are doing well without a good reason, because that can sometimes lead to a flare-up. So as you've probably gotten the sense, I'm somebody who likes analogies. So the analogy I give for therapy for IBD is think of the IBD as having matches in the house. When we first get diagnosed, you present with symptoms, meaning a fire. It's a lot easier to blow out a match than it is to put out a forest fire. So that's the idea of maintenance of remission, that we want to be able to keep that inflammation under control or catch it when it's early and just a smoldering ember or a match, and not see somebody when there's rip-roaring inflammation or a forest fire, because as you can imagine, it's a lot harder to put that out. And the reason I say that, and I give you this analogy, is because people ask me all the time, once they feel well, why can't I just stop my medications? And if I flare up, we'll deal with it then. And this is sort of the rationale for why we want maintenance therapy, because I don't want to see my patients when they're really sick and they're flaring up and it's like putting out a forest fire, because sometimes I can't do that without surgery or steroids. And if you think back to the slide I showed you before about our goals of therapy, we want to minimize toxicity and we want to minimize needing to use steroids and we want to minimize surgery and hospitalizations. And so the best way to do that is to never get into a situation where we're having to put out a forest fire. So what are the treatment options? Let's talk about what we have now, and then we'll talk about what some of the newer things are. So historically, we used to not have many options. We used to have steroids or antibiotics. So steroids are a big gun when it comes to suppressing the immune system. So if you recall, when I told you about Crohn's and ulcerative colitis, these are autoimmune diseases. I'll talk in more detail about what that means in a minute. But steroids are sort of a non-specific way to just reduce the immune system. And the reason, so they work pretty well, but the reason we don't like to have people on these in the long term is because they can cause long-term toxicity for several reasons, both because they are so aggressive in knocking out the immune system, and also because they can cause problems like osteoporosis or adrenal insufficiency down the road. So these are not ideal long-term medications, and they've fallen out of favor. We used to also treat with antibiotics, but again, this was sort of because of lack of options, and now we don't tend to do this unless there are clear infectious complications. Another option are medications called 5-ASAs or mesalamines. You may know these as medications like Asacol, Pentasa, or Mesavant. These are topical therapies. So what that means is even though you ingest them as a pill, they're not absorbed into the bloodstream. They just coat the colon, or some of them may coat the small parts of the small intestine. Think of it as a cream, but the only way to administer a cream to the GI tract is to either ingest it as a pill or introduce it into the gut directly as a suppository or an enema as a rectal therapy. But these are topical medications, meaning they're very, very safe because they're not absorbed into the bloodstream. The flip side is because they're not absorbed into the bloodstream, they really only act wherever they can reach. So if they dissolve in the colon, that's all they're going to be able to do, and they're not going to do a great job. When I talk to you about Crohn's disease being transmural, meaning it's involving the full thickness of the bowel wall, obviously this isn't going to touch that because it's only being applied topically to the mucosal or the inner layer. But these are very safe medications, so for mild disease, these are sometimes still used. The next therapeutic option are drugs called immunomodulators. And you know these as 6-MP or azathioprine, which is known as Imuran, or methotrexate. These are, again, immune therapies that target the immune system. Some of you may be on these because they were started a long time ago. Others maybe have started them because it's part of an approach that sometimes the insurer or the payer mandates, which is that we put people first on immunomodulators before we step up to biologics. The reason we don't always use these up front, or why they've fallen a little bit out of favor, is because they don't act very quickly. And when I talked to you about remission, we talked about induction and maintenance. These are maintenance medications. They don't serve as induction agents, which means we often need to induce remission with something else, and that something else is often a steroid. So if our goal is to avoid steroids, it behooves us not to necessarily initiate these medications as the maintenance therapy. But as I said, we sometimes don't have a choice because of insurance reasons. The other reason why we use these medications is to boost the efficacy of the biologics and make them last longer and work better. And I'll talk about why that is in a bit. So what are the biologics? Currently, we have 3 classes of drugs. We have anti-TNFs, which you know as infliximab, also known as Remicade or Inflectra. We have adalimumab, which is also called Humira. And we have golimumab, which is used for ulcerative colitis and is also known as Simponi. We have one anti-integrin, which is called vedolizumab or Entyvio. And we have one anti-IL interleukin 12/23, which is also called ustekinumab or Stelara. So those are our options for biologics. And then, as I said, we often use combination therapy, biologics in combination with immunomodulators or some of the other options. So historically, we used to do what we call bottom-up therapy, which meant we started everybody on a 5-ASA. And if they didn't do well, we put them on an immunomodulator. And if they didn't do well with that, we would put them on a biologic. The problem is it often looked like this, where people were getting courses and courses of prednisone because they weren't getting better. And I talked about how we ideally don't want people on long-term prednisone. Now, a short course might be okay, but if you're needing a short course every couple of months, then it turns into a prolonged course, and that's exactly what we're trying to avoid. So again, thinking back to that slide about what our goals of therapy are, this approach sort of goes against that. Particularly because what we were seeing is it wasn't this clean, and it often looked more like this, where people were getting courses and courses and courses of prednisone before we escalated. So this caused a bit of a shift in the paradigm to how we approach treating inflammatory bowel diseases. And we called this newer approach top-down therapy. So what it involved was turning that triangle upside down and starting with more early aggressive therapy with biologics, potentially in combination with immunomodulators. Now, it's sort of a misnomer because we didn't really then step down to 5-ASAs as it would imply by just turning the pyramid upside down. What we thought of is then using 5-ASAs and other complementary and alternative therapies in conjunction, but we now focus more on early aggressive therapy. And that brings us back to what we had talked about earlier about what our goals are, is that we want to induce mucosal healing, meaning get everybody not just feeling better, but all healed up inside. And we think the best way to do that is with early aggressive therapy. So we're not letting people smolder and get inflammation and coming to see us when that forest fire is out of control, but rather putting it out when it's just a spark or an ember or a match and maintaining that with a good long-term plan. So let's talk about what some of the newer therapies are to treat IBD. So we'll talk about biologics and their safety. We'll talk about biosimilars, and we'll talk about what some of the emerging and complementary therapies are. And then we'll get to your questions because I'm sure you'll have many. So I had alluded to before that we have about 5 biologics that are available to us now in 3 different categories. So what does a biologic mean, and why is this different than any other drug? So any other drug that you think of, like taking acetaminophen or Advil or Tylenol for a headache, These are small drugs that are synthesized in a lab. Biologics, on the other hand, are large molecules that are derived from the genes of living organisms. So these are antibodies that are large, complex molecules that are specifically designed to inhibit specific components of the immune system that cause inflammation. So if you remember back, I told you that inflammatory bowel diseases were autoimmune diseases. And I'm not sure people realize this, but the gut is actually a very large immune organ. And there are specific proteins and other molecules that are released by the gut in response to something around it that causes an immune cascade. So forgetting about Crohn's or ulcerative colitis for a minute, if you just think about food poisoning or any other infection, what happens is a foreign substance is introduced to the body. The body recognizes that substance as being foreign, and because we have great intact immune systems, we then attack that foreign substance, and that causes a cascade of things that lead to physiologic changes in the body that help us fight that infection or that foreign presence. And so that's where you get some of those symptoms like fevers. That's part of an intact immune system doing its job. So with inflammatory bowel diseases, these are autoimmune diseases. So what that means is, for some reason, our bodies are recognizing something intrinsic as being foreign, and our body is attacking itself. So what we want to do is knock that process out. But as I've just said, an intact immune system is important for fighting infections. So we don't want to knock everything out. We just want to knock out relevant targets that will allow our body to stop the process of attacking its own gut, but still allow it to continue with the healthy process of attacking things that are foreign. So I want to show you a picture, not intended to scare or confuse anybody, because when I see pictures like this, they scare and confuse me, but just to give you a sense of how complicated this process is. So this is an example of, this is the gut wall, and this is a diagram depicting this complex interaction between antigens or foreign stimulants or triggers and the process and cascade that's triggered when our body recognizes these. And this is similar to how these drugs work. So what scientists were able to discover is specific targets like TNF or interleukin 12 or 23 that are gut selective, meaning we think these play an important role in mediating autoimmune inflammatory bowel disease, but by knocking them out, we're doing as little damage as possible to the intact and important parts of our immune system. So thinking back to why I wasn't in favor of prednisone, part of the reason is because prednisone isn't selective. So it knocks out everything, and then it really inhibits your body's ability to fight infections. And if we look at large databases that studied the safety of our medications in IBD, the only one that was associated with an increased risk of major infections was prednisone. So we really want to not use that medication as much as possible, and unless we have to. So that's why we developed some of these more novel targets. So when we talk about having different classes of biologics, we have anti-TNFs, we have anti-IL-12/23s and anti-integrins. These are knocking out different parts of that inflammatory cascade in hopes that one of these is going to be the one in this particular patient or this particular person that's driving their autoimmune inflammatory bowel disease. Now, I said here that these medications are unique in that they can't easily be stopped and started. So why is that? So if you think of, again, forgetting about inflammatory bowel diseases for a minute and just thinking about any infection, think about how a vaccine works. So if I give you a vaccine against, say, chickenpox, what it involves is by giving you that vaccine, I'm showing your body a small amount of that virus. What it does is your body is going to recognize that virus as being something foreign, and it's going to do what it does best, which is fight foreign intruders. So it's going to mount what we call antibodies specific to that particular stimulant or antigen. So your body is going to make antibodies to chickenpox, and that's how immunity develops. Now, the reason it does that is because we just introduce a small amount and then we take it away. If I were to show your body a small amount of chickenpox every single day, you wouldn't mount immunity at all. Your body would accept it as not foreign. It would say, okay, this is something I see every day now, so let's not fight it. The same is true of these drugs. Because these are large molecules derived from living organisms, and these molecules are antibodies, if I were to just introduce them in a small amount to your body and then never show your body that antibody ever again, your body would make an antibody to that antibody. So your body would say, hey, what I just saw is foreign. Let me make antibodies to it. And then just like it would to any virus or other infection, you would become immune, which means those drugs wouldn't work. So the thought with these, because these are complex large organisms, is we introduce them to your body and then make them available in a steady state continuously so that your body never recognizes them as foreign. And that's why the dosing intervals are developed the way they are. So that's based on scientific studies in the lab where we showed how often do we have to give this drug and at what dose to make sure that it's present in your bloodstream to some degree at all times. Because if we think the level drops down to nothing, your body may mount antibodies to that drug and we won't be able to use the drug anymore. So that's one of the reasons why, unlike with other drugs, where if you miss a dose or you stop taking it and we switch therapies and you want to go back on it in a couple of years, with most drugs, that's fine. But with these biologic drugs, which are called monoclonal antibodies, we can't do that because we risk what we call immunogenicity, or antibody formation. And when I talked to you earlier about how we sometimes use immunomodulators, which are those drugs like 6-MP or azathioprine or Imuran, to boost the efficacy of your biologic, what those drugs do is they help suppress some of that immune response to limit the antigenicity of the drug, meaning it's going to make your body less likely to form antibodies to your biologic, because once you've formed antibodies, we can't use that drug anymore. It's just not going to work. So the question I get probably most often in my office is, are biologics safe? And I have a very hard time answering that question because I don't know how to answer whether anything is safe. It really depends on what we're comparing it to and understanding what each individual's perception is of the magnitude of risk. So let me tell you what I mean by that. Just to give you some ideas of risk. The risk of dying of heart disease is 1 in 5. The risk of dying from cancer is 1 in 8. The risk of dying in a car accident is 1 in 260. The risk of drowning is 1 in 1,000. The risk of dying in a bike accident is 1 in 5,000. And the risk of getting struck by lightning is 1 in 80,000. So focusing on the more common, these middle three, car accidents, drowning, and bike accidents. So again, I don't know if you consider any of these things safe, but when I think about getting into a car, I've definitely gotten into my car more than 260 times this year. And I definitely plan on getting into my car more than 260 times going forward. So if the risk of death is 1 in 260, to me, this isn't safe. So now it doesn't seem intuitive because we all get in our cars. So why do we do that? And why do we perceive this as being safe? So I think we do for 2 reasons. The first is that we focus on risk reduction. So we wear seatbelts when we drive in our car. We wear helmets when we ride our bikes, and we wear life jackets when we're on bodies of water. We try not to get struck by lightning by not standing in the middle of a lake during an electrical storm. So all these things help us mitigate that risk. The other thing we ask ourselves is, well, how important is this thing? So when I think about skydiving, for example, that's probably really risky, and I don't know if I can convince myself that I can mitigate the risk by wearing a parachute. But it also depends on how important it is to me. And some people will say it's very important and I really want to do it, and they do it. And other people will say, well, I don't want to, so I choose not to. So it's important to understand what are the alternatives. So anytime we talk about risk of drug, we have to talk about the alternative. And what everybody wants me to tell them, or what I wish I was able to offer, is the alternative of, you don't have inflammatory bowel disease and you don't need treatment. But that's not an option that's on the table when we're having these conversations. The options are treated disease versus untreated disease. So that's where, when we're talking about risk of therapy, it's compared to what? And it's compared to untreated disease. So what is the risk of untreated disease? As I mentioned, inflammatory bowel diseases are chronic illnesses. So unlike something like a pneumonia, which I can treat and then it's gone forever, I can make IBD be in remission, but I can't make it go away. It's a chronic illness. So if left untreated or undertreated, that's not without risk in and of itself. So what are those risks? So to give you some diagrams that will hopefully illustrate this point, the chance of needing surgery for untreated Crohn's disease is about 40% within 5 years, meaning 40 people will require surgery. Within 10 years, it's about 50%, and within 20 years, it's about 80%. So you can see that if left untreated, the vast majority of people with Crohn's disease will require surgery. What about cancer? The risk of colon cancer after 30 years of colitis is about 1 in 12. So 1 in 12 people will go on to develop colon cancer if I don't mitigate that risk. And the way we mitigate that risk is by treating the disease. So comparing that then to the risks of treatment, what are the risks of treatment? So any drug can have side effects. And the way side effects, if you Google it or look it up on a product monograph, is in the clinical trial where we studied the drug, anything that anybody developed had to be reported and is reported as a side effect. So that's why when you look up side effects for drugs, you'll see a really long list of things. So the question becomes, well, how common? Was it a couple of people reported these things and it was just a coincidence, or are they actually due to the drug? So that's an important conversation to have with your doctor and to ask how common are these side effects and how likely are they to be related to the drug? There are some common side effects for biologics. So we talk about injection or infusion site reactions. So biologics, at the moment, the ones we have in Canada are not oral medications. So they're either injected or given by an IV. So you can get some local irritation at the site. Like any drug, people can get allergic reactions. As I talked about, because these knock out parts of the immune system, it can theoretically make you prone to certain infections. And that's definitely more significant in certain groups of people. And I'll talk about that again in a minute. And the last thing that people always ask me about is, what about cancer? And the reason I bring this up is because several years ago, what came out of some studies was that we made an observation that in people who were treated with combination therapy with immunomodulators and biologics, particularly young men, there was an increased risk of something called hepatosplenic T-cell lymphoma, which was an almost fatal cancer. Almost always fatal cancer. So obviously we would never treat an illness with drugs that posed greater risk than the illness itself. So this caused us all to scratch our heads and say, should we be taking all of our patients off these medications? And if I wanted to scare you, what I would say is it's going to increase being on combination therapy increases the likelihood of hepatosplenic T-cell lymphoma 3-fold. Now, just to get back up to help you understand what that means, in patients who are not on combination therapy with inflammatory bowel disease, the risk of hepatosplenic T-cell lymphoma is 2 in 10,000. By putting you on this drug, by increasing the risk 3-fold, we're increasing it to 6 in 10,000. So, and I've given you this illustration to offer some perspective. This is 10,000 people. So you can see that even though it's a 3-fold or 3 times increased risk, it goes from being infinitesimally small to remaining incredibly small. Very, very unlikely. The vast majority of people will not develop this side effect or this complication. So when we think back to how common colon cancer was in untreated colitis, which was 1 in 12, I'm a lot more worried about the very realistic possibility of getting colon cancer from untreated disease than I am about getting hepatosplenic T-cell lymphoma from treated disease. Now, the other thing I'll tell you is that we've since realized that this risk is probably not actually due to the biologic and probably due to the immunomodulator, which is why we sometimes try to keep certain groups of people off immunomodulators in the long term. So we noticed that the risk increased in people who had been on them for many decades, particularly young men. So in certain populations of people, we may want to get them off that drug if they've been on it for a long time already. And it's a conversation to have with your doctor if this risk is one you're not willing to take. So when we talked about some of the other potential risks, we talked about infections. So when we talk about mitigating that risk in the same way that we use seatbelts and life jackets and bike helmets and all the other safety precautions that we take, when I put my patients on immunosuppressive medications that suppress their immune system, one obvious thing for me to do to mitigate risk of infection is to vaccinate them against preventable infections. So I'm pretty strong in recommending this to my patients. And it's exactly for this reason, because I want to keep them safe and I want to minimize the toxicities of their drugs. I put sunscreen here because I didn't talk about this much in the other slide, but another risk we see is in certain skin cancers in patients treated with biologics. Now, we don't get as excited as we did with hepatosplenic T-cell lymphoma because these are usually treatable skin cancers and not ones that are going to limit your life expectancy. But again, we can mitigate that risk by wearing sunscreen and doing regular skin exams. So these are all things to think about when we're thinking about the risks of our drugs. So to summarize, anytime we start any therapy, we always want to weigh risks and benefits. What I try to convey to my patients is the biggest risk is active disease, not active treatment. And it doesn't make sense to recommend a therapy that carries greater risk than the risk of the disease that you're trying to treat. Along those lines, we mitigate risk as much as possible and whenever possible. And that's what drives some of those recommendations for vaccination and skin exams and things like that that sometimes may otherwise not seem to make sense. Okay, so what are biosimilars? Biosimilars are a group of drugs that most recently hit the market. So these are new for patients and just as new for doctors. So we're all just getting used to this. So a concept that's quite familiar to everybody is that of a generic drug. So a generic drug exists when a company makes their product and the patent on that product expires, and then you're able to replicate it exactly and market it under a different name or even the same name as a generic drug. Biologics, because they're large, complicated molecules, and because the process by which they're manufactured is proprietary, you can't make an exact replica of that drug. It's not possible. They're too big, they're too complicated, and the process is too relevant to the synthesis of the drug. So instead, in an effort to contain costs of these otherwise very expensive medications, they've been reverse engineered, where somebody has taken that existing biologic drug and brought it to a lab and tried to copy it. Now, it's not going to be exactly the same, and that's why we don't call it a generic, because it's not identical. What makes it similar and not the same is that it acts the same way in the body, meaning when it's studied, the studies will show that there's no meaningful difference in the quality, safety, and efficacy of that drug when used to treat a certain disease. It doesn't mean it's the same, it just means it acts in a similar way, and then it gets the designation as a biosimilar. So at the moment, we only have one biosimilar in Canada, and that's for infliximab. So you may know infliximab as Remicade. The biosimilar is called Inflectra, but it's still being called infliximab because it's a biosimilar. And it's been studied in ankylosing spondylitis and rheumatoid arthritis and shown to have no meaningful differences in quality, safety, and efficacy in those diseases. Now, the reason I mention those diseases is because when a drug hits the market or a biologic, in order to be able to use it for a certain disease, you have to study it in that disease. And a great example is Stelara or ustekinumab. So everybody knows this, or some people know this as a new drug for Crohn's and colitis, or for Crohn's disease, but it's not a new drug at all. It's been used for psoriasis for a very long time, but we couldn't use it for Crohn's disease until we studied it in a Crohn's disease population. What's unique about biosimilars is they don't have to go through that process. So once they've been shown to be similar enough or equivalent in some diseases, you can generalize or extrapolate across indications, meaning Health Canada allows us to say, because Remicade works in ankylosing spondylitis, rheumatoid arthritis, and Crohn's and ulcerative colitis, and because this biosimilar is similar in certain diseases, we don't have to now study it in all of these diseases, and we can assume that it's similar in everything. So that caused a lot of concern when the biosimilars first became available, because we said, well, my Crohn's disease or my ulcerative colitis patients, they're different than patients with rheumatoid arthritis. It's a different disease, and how do I know the biosimilar is going to work? The good news for us in Canada is there's a lot of what we call real world data from around the world, meaning after these drugs became available, uptake occurred in other countries, and there's a lot of experience in Europe showing that indeed these drugs probably do work similarly in Crohn's and ulcerative colitis as the innovator biologic, which is Remicade in this case. And so they probably do act similarly when used across indications. So the data, the real world data we have, because these drugs have been around for a few years in Europe and other parts of the world, is they're probably equivalent. So then another question we get is, well, what about switching back and forth? And if you remember when I told you before that when you go on a biologic, we always want to keep that biologic in a steady state in the body, because otherwise we run the risk of your body recognizing it as foreign and making antibodies to it. So a question I had when I first learned about biosimilars is, what if they're not similar enough and then your body makes antibodies to infliximab and then recognizes the new drug as foreign or prevents us from being able to go back on the old one? And the answer is that the jury's still out on that. There is one study that was designed specifically to look at people switching from infliximab Remicade to Inflectra, or to the biosimilar in that country, which had a different name. And this was a group of 400 patients. Only 250 of them had Crohn's or ulcerative colitis. The rest had other diseases. And it was designed as what we call a non-inferiority study. So when you look at the outcomes, in the group that stayed on their Remicade, 26% flare. So that's the natural history of the disease. 26 went on to have a flare-up. When you looked at the group that were switched to the biosimilar, 30% went on to have a flare-up. So you might see those numbers and say, hey, like, obviously switching is worse because that group did worse. But the study wasn't powered or designed in that way. It was designed as a non-inferiority study. Now, that's a statistically complex conversation that's beyond the scope of what we're going to talk about today. But the take-home point is the only conclusion we can draw from that study is that it was not inferior. So based on the statistical setup and design of that study, which was a non-inferiority study, it showed that switching was not inferior. Does that mean it's equivalent? Does that mean it's better? Does that mean you can't draw those conclusions, because that's not what that study sought to prove. So again, I know that's a nuanced and complicated explanation, and hopefully I didn't confuse you more, but the take-home message is the jury's probably still out on that one. I think we need more data and we need more experience. And I personally probably wouldn't switch my patients back and forth unless there was a really compelling reason to do so. So that's a conversation to have with your doctor, but I probably wouldn't just do it just because. I'd probably have a really good reason. And in my practice, if I were to do that, I'm aggressive then about following that patient and looking for early signs that they might be flaring up, so that I'm not putting out a forest fire a year down the road. Okay, so I'll quickly run through some emerging therapies and leave some time at the end for questions. The reason I'm going to run through these quickly is because they're not ready for prime time, and I don't think they're worth having a long conversation about. So there are several new biologic therapies on the horizon, and I've listed 3 here. What's unique about them, so tofacitinib, which is currently being used in the United States for ulcerative colitis, is appealing because unlike all the other biologics, this one is an oral medication, so that's promising. And then we have some novel targets. So when I told you that we're always looking to find the perfect target to knock out, so we're only impacting the body's autoimmune process that's driving the inflammatory bowel disease and not knocking out the whole immune system, these are novel targets, so that's always appealing. And then there are some non-immune therapies that I'm going to spend a few minutes talking about. So when we think about what causes Crohn's or ulcerative colitis, we know that it's probably a complicated interaction between genes, the environment, the immune system, and the microbiome. So I've just talked about immune therapies. That's everything we've talked about up until now. At the moment, although this is likely going to change in the next 10 years, but in the moment, we can't change your genes. In terms of the environment, we sometimes think, oh, there's nothing I can change, it is what it is, but there are certain modifiable risk factors that do drive disease, and a great example is smoking, which we know can make Crohn's disease worse. So those are modifiable environmental factors. And then the last thing I'll talk about briefly is the microbiome, simply because it has a lot of excitement in the press. So what is the microbiome? So the microbiome is a collection of organisms, fungus, bacteria, viruses that live inside our gut and help drive certain physiologic processes like digestion, or even they help sort of control that immune process of the gut. So they play an important role in driving that gut immunity. So by altering the microbiome, by altering the makeup of those organisms, we think we may be able to manipulate disease. So how would we do that? There's two ways that I can talk about that would do that. One way to change the makeup of your microbiome would be to transplant you with somebody else's microbiome, and that's called a fecal transplant. And that we use already commonly for treatment of certain infections like C. diff. And the other is by changing your diet. So as far as fecal transplant, this has actually been studied quite extensively in inflammatory, I shouldn't say extensively. So this has been studied for quite some time in inflammatory bowel disease because it's really appealing. And without getting into all of those studies, what I'll tell you is, again, the jury's still out, and this probably isn't ready yet for prime time. The data have been conflicting and the studies have not been robust. So some studies will show that people do better, other studies will show that people do worse. And there's methodologic problems to some of those studies. The protocols are inconsistent. And the overall conclusion is we don't have enough data to recommend this as a therapy. And the same goes for diet. So I've given the example of the specific carbohydrate diet because it's been talked about a lot in inflammatory bowel diseases. But again, similar to fecal transplant, the jury's still out, the data are conflicting, and we don't have large or robust studies to be able to say with confidence that any change to your diet or a fecal transplant are going to actually alter the natural history of your disease or induce or maintain remission. So we're not ready yet. There are some complementary therapies that have been studied. So the best data is probably around curcumin or turmeric, or a probiotic called VSL number 3. In general, these have been studied as an adjunct to therapy, so they're not going to induce or maintain remission on their own, but when used in combination with other standard therapies, there's some modest data to show that they may support the efficacy of your drugs. We've talked about mindfulness, acupuncture, and other sorts of stress reduction as helping improve symptoms. And then I put this in because I anticipated there might be a few questions, which is what about medical marijuana? And similar to microbiome alteration, the data aren't robust and they're somewhat conflicting. So to give you an example, one study showed that there was an improved sense of well-being and health and decreased rates of depression in patients with Crohn's or colitis treated with marijuana. But then there was another study that showed a 5-fold increased risk of surgery comparable to cigarette smoking in Crohn's disease. So again, these are small studies. They're not methodologically perfect, and the results are conflicting. So again, I don't think we can confidently make recommendations for using any of these complementary therapies to induce or maintain remission in inflammatory bowel disease. So hopefully I've met the objectives and just given you a sense of what we sought out to discuss. So I hope you have a better understanding of what IBD is, what our goals are for treatment. I hope you have a good understanding now of what some of the treatment options are, as well as what some of the newer therapies are, why we use them, what some of our concerns are, and a little sense of their safety. So now I'm going to open it up to questions.
Great. Thank you so much, Dr. Zenley. That was an incredibly informative presentation. Thank you so much. If everyone doesn't mind, we're running a little bit over time. We will let this webinar run just a little bit over the time so that we can get to as many questions as possible. So the first question I have is related to biologic treatments. The question is, what sort of criteria do doctors use when making the decision about a patient's biologic treatment?
So that's a great question. And, there isn't a black and white answer to that. So the human body is a complicated thing and everybody presents in a different way. So there aren't a clear list of criteria. So it depends on a conversation between the doctor and the patient, taking into account risks, benefits, and goals. So when I meet with my patients and we're making that decision, sometimes it's based on just my global assessment of disease severity. And if I get the sense that there are features of more aggressive disease, I may want to treat that more aggressively up front. So I had given you before the analogy of of not wanting to ever have to put out a forest fire, because that's hard to do. So if I think that there are characteristics of the person in front of me that are suggestive of a more aggressive course, then I may recommend more aggressive upfront therapy because I think it's necessary. And nobody knows exactly what those are. It sort of depends on a lot of features, but some examples would include how extensive the disease is when we stage it, so how much of the GI tract is involved. Sometimes younger people have more aggressive disease. People who needed surgery early on in their presentation or who have needed a lot of steroids, we think of as having more aggressive disease. And sometimes younger age at presentation is a risk factor for more aggressive disease. Similarly, I had talked about how Crohn's can involve the full thickness of the GI tract. So in patients who have had penetrating complications, meaning abscesses and fistulae, once the infectious component of that is taken care of, I might be more aggressive and recommend a biologic up front. Personally, I think biologics work great, so I have a low threshold to recommend them. But in people who are more risk averse, and this is where it becomes an individualized, shared decision-making process with the patient, if their disease is relatively well controlled on a less aggressive therapy, and they're not excited about being on a biologic, then that's somebody who I may consider more of a step-up approach and start with some of the topical therapies first.
Great, thank you. We have a question here. Does the use of biologic or biosimilars impact fertility and or pregnancy?
That's a great question that I get a lot. So, and the short answer is no. So the biggest risk in pregnancy is active disease. If the disease is treated in whatever which way we need to treat the disease, then most women will go into their pregnancy no different than an equivalent who does not have Crohn's or ulcerative colitis. So, and in fact, one analogy I give, so this isn't used so much anymore, but in some of the earlier fertility treatments, they actually used to use biologics to boost implantation. They thought it helped with fertility. So I don't know that we still do that anymore, but that was the theory. So the best way to optimize both fertility and success and a successful, healthy pregnancy is to go into that pregnancy with well-controlled disease, which with whatever drug is needed to achieve that goal.
Okay, great. Are there treatment approaches that are different when you're treating a man versus a woman?
So that's a really, really interesting question. And the answer is probably not, but I don't know. This is a new trend in medicine. Historically, we've studied things more in men than in women, and we've generalized the treatment to women. So we've assumed that because something was safe or because something was proved to be effective in a pooled group of patients, that we could extrapolate from that it must be safe in everybody. And over the last few years, we're starting to recognize that there are gender and racial disparities in disease. So we can't always generalize. Now, that being said, I don't think we've seen that disparity to the same degree in inflammatory bowel diseases as we have in like cardiac diseases, for example, where there are clear treatment differences, where one drug might be effective in men and harmful in women. We don't see that in IBD yet. And I don't think we're going to, because looking at our studies, they have had a pretty equivalent spread. But it's a really interesting question that you bring up. And I wonder if our understanding now that we're more attuned to the phenomenon will change, and if our study design will change as time goes on. But for the moment, we don't see any difference.
Okay, thank you. Has the success rate for biologics improved over time?
There's two ways to answer this. So it's not that the biologics are getting any better, but our ability to use them to their best is improving. So the more we understand how to use biologics and the less scared of them we are, the success rates improve because we use our drugs better. Meaning, before, if we were more reluctant to dose escalate, or we didn't want to be so aggressive up front, or we waited, so again, using that analogy of the forest fire, nothing is going to be as effective at putting out a forest fire as it is going to be at blowing out a match. So even if I have the strongest extinguishers and the best ones in the world, if I'm trying to put out a forest fire, it's not going to work as well as trying to put out a smaller fire. So the same is true of biologics. So we see people staying on them longer now, meaning they seem to be working in more people, probably for several reasons. One is that we're using them earlier on. So we're just putting out a little fire and then keeping it at bay, as opposed to trying them and failing when things are too out of hand. The other thing is we're able to check levels of the drugs in the blood system for some of these biologics, not all of them. And so when we can check a level, we can actually measure, when we initially dose drugs, we generalize. So we say in most people, this is the dose that's needed to be effective. But the nuance now that we have with some of our biologics is we can say, well, that's great and that's a good starting point, but let me tailor this therapy to this individual at this particular time. So you may metabolize something differently than I do, and I may metabolize something different. I may metabolize a drug differently today than I do in 6 months when my disease is more or less active. So what we can do is actually measure the drug level in the person and tailor the dose or dosing frequency of the drug in that particular person to ensure that the levels are robust and to minimize the likelihood of making antibodies. And the third thing is that we've gotten a lot more comfortable with combination therapy with immunomodulators, which has the same effect of boosting that drug and minimizing antibody formation. So I think all of those characteristics combined have made us use these drugs to their fullest potential. And I think for that reason, we're seeing that people are staying on them longer because we're using them better.
So why do biologic medications sometimes stop working? Do we know that?
So there's a whole number of reasons why biologics can stop working. So probably the most common is that antibodies have formed. Now, as much as we try everything we can to prevent antibody formation, sometimes it just happens, and that's something we have to be aware of. So sometimes the drug will stop working for that reason. The other time that drugs stop working is if they've never really worked in the first place. So it's not necessarily that they stopped, it's just that they never really were that great, and you may have been seeing benefits because of something else. So sometimes if people are on steroids at the same time as their biologic, sometimes it's the steroids that get them better, and then when we slowly take off the steroids, we see their disease become more active, and that's because that biologic was never really the right drug in the first place. And that gets back to some of those targets that I talked about before, that we talked about how when we're trying to knock out the immune system, we're picking one specific area rather than, throwing some very potent immune suppressive on that's going to suppress the whole immune system. We're trying to pick selective targets, but the upside of that is that way we don't impact the immune system as much when it wants to do good things like fight infections. The flip side of that is everybody's disease is probably a little bit different. And while some people may have disease that's mediated by TNF, so you block TNF and they do great, other people's disease may be more driven by a different pathway. And so picking a new target is going to be more helpful. And that's why sometimes that one class of drug might not work, but another class might work great.
Thank you. Are there any new or emerging treatments that are specifically looking at pain symptom management for IBD?
Did you say pain symptom management?
Pain symptom management, yes.
So, pain, it depends on what the cause of the pain is. So there's no specific drug looking to reduce pain and only pain. At the end of the day, what we're looking at is what's driving your symptom. Is your symptom being driven by active inflammation? In which case, all the drugs I talked about are used to treat active inflammation. Or is your symptom being driven by something else? So some people with Crohn's or colitis have symptoms that have nothing to do with inflammation. And sometimes those symptoms have nothing to even do with their disease. Sometimes they do. So an example I can think of with pain is some people who have surgery, whether that's for Crohn's or colitis or because you needed your appendix out for some other reason, or your gallbladder, or because you were kicked in the stomach playing judo like my father-in-law and you need to have surgery. When the body heals from surgery, scars can form. And sometimes those scars cause pain. So when I see people sometimes with Crohn's or colitis who have had surgery, they have chronic abdominal pain. That isn't because of active inflammation. it's because of a scar. And the reason that's relevant is because me treating them with aggressive anti-inflammatory medications may be helpful for some other reasons, but probably isn't going to treat that symptom of pain because that pain is caused by something else. So even though the symptoms themselves are really important, what's more important to me from a treatment perspective is what's the underlying cause of that symptom, because that's where I have to target the therapy.
Okay, thank you. This is our last question for this evening, and may not be one that you can answer, but I thought I'd put it out there. Someone wanted to know, how close are we to finding a cure for IBD?
I wish we were closer than we are. So I don't know that we are anywhere near finding a cure for IBD. What we're close to, and what I think we're a lot better at now than we were 5 or 10 or definitely 15 or 20 years ago, is maintaining deep remission in IBD. So I think we're getting really good at getting people into remission and keeping them that way for the rest of their lives, so that they can live their life without ever remembering that they had Crohn's or colitis in the first place. As far as curing it, I haven't heard of any potential development as far as finding something to make it go away completely.
Okay, thank you so much. So thank you, Dr. Zenley, for your expertise tonight, and thank you to all of our participants for your questions. This was a really great webinar and Q&A. I just want to end, as we're drawing near the end of a webinar, I just wanted to take this opportunity to make sure that everyone listening knows that we'll be following up with you afterwards to get your input. And so we'll be sending you a survey to find out, get your feedback and find out if there's any other topics that you'd like us to cover for our future webinars. We'll also be sending you a link to the recording of this webinar, so if there's anything you want to refer back to, you can view that link. I also want to point you to the direction of our other education programming. So we've got our information brochures and videos. We also have a peer-to-peer online support program called Gutsy Peer Support, which you can find by going to gutsypeersupport.ca. And also we have a washroom locator app called Go Here, which you can find at gohere.ca. And if you have any questions about any of these programs, please reach out to us at support@crohnsandcolitiscanada.ca. Finally, we invite you to make more discoveries and breakthroughs possible. Now on its 23rd year, Gutsy Walk has raised over $35 million for research, advocacy, and patient programs, and we'd like you to be a part of it. With your support, cures for IBD are just steps away. Register now at gutsywalk.ca and join us on Sunday, June 3rd at a location near you. Again, thank you very much for joining us, and thank you again, Dr. Zenley, for taking your time out of your very busy schedule and for helping us with the webinar tonight. I hope we've answered some of your questions, and this concludes tonight's webinar. Thank you so much, everyone. Good evening.